This conference will now be recorded.
Good morning, everyone. Thanks for joining us here today. We're just going to wait a few more minutes for others to join, and we'll get started shortly.
Good morning, everyone. It is Mike. I see 8:03, so let's get started. We do have a full agenda for today. As a reminder, today's meeting is a rerun of the agenda that we had for the Improve Care Now Community Conference last month. So if any of you were at the community conference in person, feel free to stay on this call if you'd like, but there won't be any new information presented. So if you wanted to reclaim this 30 minutes, that would be fine. Next slide. So our agenda for today, a little bit of a status update. We'll talk about visit completeness and data completeness. We'll talk about some of the workflows and processes for the final visit of each patient, and sort of using that as an opportunity to tie up loose ends. We will quickly review some of the colonoscopy scoring information that we presented at the beginning of the trial, but as patients are completing their last visit, now is a really good time to play catch up. So we'll review some of that content and then talk about our overall timeline and what to expect in the year ahead. Next slide. Keep going. So, as crazy as it sounds, November 1st marks the beginning of our 5th year on this combined journey together. And more than a journey, it really has been an odyssey. And so I would just like to thank all of the coordinators and all of the site investigators and all of the staff that make this project work, for everyone's continued interest and perseverance and tenacity, because our patients and their parents deserve strong evidence regarding important clinical decisions, not just opinions. Interestingly enough, when I Google imaged the photo that you see at the bottom for Odyssey, the Homer book was not the first image to appear, but rather, next slide, it was the Honda Odyssey. And I think many times the combined experience has felt like we are all cramped up in the minivan and going to the county fair together. So it was an interesting image as well. Next slide. And hopefully Combine has not felt like Assassin's Creed Odyssey, where we are charging into massive epic clashes. Next slide. So we now have 36 active sites, and collectively, at least as of the beginning of last month, have randomized 262 patients. So 35 sites have recruited at least one patient. Cincinnati and Children's Hospital of the King's Daughter were our leading sites, with 20 patients each, although in September, Cincinnati randomized an additional patient, giving them a little bit of a notch up. Next slide. Here is our recruitment by site. And again, we are growing a little bit taller each month, which is fantastic. Next slide. September had looked very strong for us. We had 7 patients randomized by the last week of September, which took us to 269 patients. Again, these slides are about 2 weeks out of date. Sites randomizing patients in the first couple weeks of September included UNC with 2 patients, Cincinnati, Michigan, Nemours, Orlando, WashU, and Nemours, Jacksonville. Next slide. So just in case you are wondering who are our patients that have been randomized so far, a little bit of that information is shown here. About 66% are male, not unexpected given the Crohn's disease predominance in males during the childhood years, as well as the fact that some female patients of childbearing age would not qualify for the study if we had reproductive concerns. Mean age 13.9 years, so fairly typical for a pediatric Crohn's disease population. Our study is primarily white, but I'm pleased that we have some degree of diversity, and notably 10% African Americans. In terms of the infliximab to adalimumab ratio, again, 71% infliximab, 29% adalimumab, which I think pretty well mirrors clinical practice. Next slide. In terms of patient status and where are we at with following all of our patients, you can see at the top here that 75% of randomized patients remain in follow-up. Of those, 71% are still undergoing treatment with study drug, and 29% have stopped study drug for one reason or another. The most common reason for stopping study drug is that patients met one of the components of our primary endpoint, and so by protocol have stopped study medication. You can see at the bottom, 12% of patients have completed the study. And in the middle now, 33 patients or 13% have had an early termination or withdrawal for one reason or another. So we are actively following a large number of patients. This is a very busy time in the study for us. Next slide. Keep going. So this just shows a little bit about how we're doing with recording study visits. At the beginning, 100% of patients will make their first visit, of course, because that's required for screening and randomization. And as we progress through each of the visits, we're hitting about 80% or so during the first 6 months, and just slowly dropping off with each subsequent visit. Some of that slow drop-off reflects loss to follow-up or withdrawal or early termination. But I think we also have opportunity to improve. And so this is a reminder as we are heavy in the midst of follow-up. Use the visit schedule report. Make sure that patients are scheduled for visits during their windows, and make sure that those visits get recorded in the database. If patients are not scheduled for visits, work with the docs and nurses and scheduling teams at your sites to get those visits scheduled so that you can see your patients, take good care of your patients, and record their data into the Combine case report forms. Next slide. We've discussed this before, but there are a number of consequences for missed visits. Most importantly, for patients who don't have a minimum of one visit recorded in 6 months, the study pharmacy will automatically hold future shipments. Again, as we are in follow-up, we expect visits every quarter or every 3 months. When a patient has missed 2 visits or hasn't had a touch point by the site in 6 months, as a safety precaution, we do not dispense them any more medications until that visit is completed. Missed visits are also a missed opportunity to assess and document whether patients have achieved primary endpoints, to record concomitant medications, to document AEs or SAEs, lab tests, and other crucial data. And finally, missed visits are protocol deviations and need to be documented on the deviation logs as such. Next slide. Data completeness. We've had a lot of progress here. I know Catalina has been querying many of the sites, and many of the sites have been responding, which is fantastic. But we still do have a little bit of room for improvement here. Everything that is highlighted in yellow comes from the Improved Care Now registry forms rather than the Combine specific case report forms. Again, Combine is an add-on to the Improved Care Now registry. We capture in Combine only those elements that are not routinely captured in the registry, but it looks from what's highlighted in yellow that for many of our sites, the Improved Care Now registry is incomplete. And so these are labs where it's not too late to go back and enter them if your sites have done those tests in prior visits. And I'm certain that many of these tests have been done. Usually you will get a CBC package, which includes both a white count as seen in the top line and a hematocrit, which is seen in the second line. And so there really should be no discrepancy between the percent of white counts and the percent of hematocrits that we're able to find when we look through both databases. And so I think that we can probably boost each of the yellow lines by 20% just by recording, just by doing our everyday work of keeping the Improved Care Now General Registry up to date. Next slide. Okay, I'm going to shift gears to Anne, who's going to talk a little bit about that final visit and using this as an opportunity to tie up some loose ends and some tools and checklists that she has created.
Good morning. It's an exciting time as most of us are having patients that are completing their 2-year study. So we have created a new patient checklist that is available now on the SharePoint site. So let me take you through some of the things that we'd like for you to do when your patient completes. So next slide. Okay, so first of all, let's see. If the patient has not agreed to continue follow-up and is ready to complete the study, we need to complete Visit 10 CRF, complete a full data review. So this is what we're trying to do here, is that when you close the patient, you do not have to go back and revisit. So this is the best time to really go through and do a complete review to make sure that everything is in there, and then you never have to go back and touch this patient again. So you want to, after you do the full data review, you want to make sure that their study medications have been discontinued, and you are going to mark the patient as that the patient has completed the study, and you're going to find this on completion early termination tab. So that's kind of the breakdown of the steps that are needed once your patient has their final visit. And next slide. On the patient completion checklist, as I mentioned, this is up on the SharePoint site, or just contact me and I can send this to you directly. But we have each of the pieces that we'd like for you to go through and check. So it's a great time to sit down with the PI and coordinator together to talk about study endpoints, closely review these, certify them if they haven't been already, or see if the patient may have met a study endpoint that you may have missed. Go through your exceptions aging report. All exceptions should be resolved by this point. Each visit tab, please review that and see if there's any missing data that needs to be entered. If the data is not available, please mark no or NA in the appropriate field so that we know that it hasn't been missed. Remember that each combined visit should have a corresponding ICN visit, and the same thing, each ICN visit should have a combined visit either through the visit tab or as an additional visit. Next slide. Some of the reports that should be essential that you should be looking at during this final review are right here. So take a look at the patient schedule report. Is provider review needed on anything? What are the exceptions that are open for this patient? And please review the adverse event listing report to see if there's anything that needs to be closed or resolved, or to verify that it is ongoing or unknown. Next slide. These are some of the other reports that are going to be super helpful for you to review also. So please check out the PRO summary report. Ensure that all pros have gotten recorded and have been sent to Philadelphia. Check out the hospitalization report. Is there anything that needs to be set up as an SAE? And ensure that all of the documentation has been gathered for those hospitalizations. Review the ConMed report. Is there anything that's open, anything that has stopped, anything that needs to be fixed on this? Please do that now. And take a look at the research labs to ensure that you've recorded that you've sent them, or perhaps that you already know that they're missing. That's fine. Next slide. And one of the things that is super easy to do is to check that the combined and ICN visits all align together. So what this slide represents, it's the top line is a picture from the patient schedule report that you find in Combine. The left hand is what you can find in ICN registry visits, a list of those visits. And then on the right hand is how you can ensure that everything is recorded. So as you see that these all align as far as visit 2, 3, 4, 5, then the patient has a few additional visits, ICN visits. So make sure that those are recorded as an additional visit within your combined database. And it continues on, 6, 7, 8 are all aligned. We have another additional visit. Ensure that documentation is in there, and then visit 9 and 10. So it's a good way to check both Combine and ICN to ensure that all your data is matching up correctly and is entered. Next slide. Okay, going back to the patient completion checklist, this is what you're going to find in the middle of the list. So make sure you're checking for the labs, all colonoscopies, they should be entered. This is a PI responsibility to be putting in that data. Has a study medication, has it been returned and documented? Race and ethnicity, are they in the ICN registry? Have you recorded all your follow-ups? Any meds should be reviewed. All the PROs have been forwarded to Philadelphia, and all your protocol deviations have been reviewed and entered into the REDCap system. So again, these are the tabs are outlined in red, are ones that you should all be visiting and checking to make sure that everything is complete on these sections. Next slide. Okay, please review all your adverse events and your SAEs. Remember that any patients who have been off medication, still you need to report SAEs up until the very end. You only need to report AEs 14 days after they've stopped study medication. But it's one of those things that we often forget, that if they're off medication, we still need to report those SAEs. And ensure that all the final forms have been completed and have been signed off with provider review. Next slide. Okay, so that's it for the final review. Please contact me if you have any questions at all about what to do with your patients. Patients that are on study drug and end at the 2 years are eligible to be unblinded. So please shoot me an email and I will arrange to get that set up for you as well after all your final documentation has been put in. So now to Dr. Adler. Is he on the call today? I don't see him. So Mike, you might have to do this part.
That is fine. Yeah, I know he was going to be on either today or Thursday. I can't remember which day.
Right, he was trying to get on for today as well. He's definitely going to be here on Thursday.
Okay. Okay. So why don't I can do his slides, and we're a bit short on time, so it's going to be an abbreviated version, anyways. Let's go. All right. So you all know that by protocol, we ask that if a colonoscopy was done either shortly before enrollment in Combine, either at diagnosis or to restage disease prior to starting the anti-TNF, or if colonoscopy was done at some point during follow-up, we record those in the Combine database. This is because as we were putting together the protocol, we heard from our community very clearly that endoscopic healing is an important endpoint for kids with Crohn's disease. I totally agree. And so this is the opportunity for us to put our money where our mouths are and record data that we can use to analyze endoscopic healing. And the, believe it or not, simplest current index for colonoscopy scoring in Crohn's disease is called the SESCD, which is the simple endoscopic score for Crohn's disease. And this system scores the severity of endoscopic findings in each of 5 segments shown below: rectum, left colon, transverse colon, right colon, and ileum. And the scoring is shown on the table here, and the next couple of slides give examples of this. Next slide. And so one component is ulcer size. And let's sort of scroll through all of these. I know Jeremy had animated them. But a small ulcer is 1 point, a large ulcer is 2 points, and sort of a large ulcer where you can't tell where one runs into the next is 3 points. Next slide. Keep going down. So this is the proportion of the surface that's visualized in each segment that is involved with ulcers. So less than 10% is 1 point, 10 to 30% is 2 points, and greater than 30% is 3 points. And so if you have teeny ulcers covering the entire surface area, you'll get 1 point because the ulcers are small in the prior component, and 3 points here because nearly all of the surface area is covered with ulcers. Next slide. The next component is the affected surface area, and again, less than 50% is 1 point, 50 to 75% is 2 points, and greater than 75% is 3 points. Next slide. The next component is narrowing, and if there's no narrowing, it's 0 points. If there's a small narrowing, which you can easily get the scope past, it's 1 point. Multiple narrowings, although you can pass the scope, 2 points, and if it's strictured down so tightly that the scope can't pass through, 3 points. Next slide. And then the simple endoscopic score can then be summed up, and you can get categories for that based on what is presented on this slide. And we can do that on the back end as we analyze all of this data. Next slide. And to the extent that even the simple endoscopic score may be too complicated for us and all of our clinical colleagues to record accurate data for, Jeremy has proposed a new physician global assessment of colonoscopy, which basically collapses things to 2 segments, the ileum and the colon. And each of those segments, you will do a physician global assessment to categorize as endoscopic remission, minimal disease, mild disease, moderate disease, severe disease, or not assessed. And there's a note at the bottom here that's super important about if the IC valve is, can you go back one slide? If the IC valve itself is strictured and it's really located just to the valve alone, we score that in the ileum rather than the colon. Let's keep going. And so again, normal is fairly self-explanatory. Keep going. Keep going. Minimal, again, just very few scattered aphthae. Keep going. Mild, slightly more aphthae, maybe a little bit more surface area involved. Keep going. Moderate, again, looking much like Crohn's at the time of diagnosis. These are good images from Jeremy. And then let's go through to severe. We can look at those photos as well. So big pseudopolyps, extensive ulceration, linear ulceration, bleeding. Okay. Keep going. All right, and so in the last minute and a half remaining, I just wanted to do an overview of our timeline and the year ahead. Keep going. And so as I mentioned in the beginning, we begin our 5th and currently funded final year of the project on November 1st. Unfortunately, we've now recruited only about 2/3 of our planned sample size. We continue to discuss with PCORI about the possibility of a project extension, but I'm not sure that that is going to be possible. And so to guarantee a minimum of 1 year follow-up, We will plan to stop recruiting patients at the end of October, and so we have about 3 more weeks or so to recruit patients for Combine. At that point in time, we will close randomization until we hear otherwise from our funder regarding a extension. And so now is the time to be doing that last push at your sites, identifying, pre-screening, consenting, and getting patients randomized prior to Halloween. Next slide, which will be our last for today. So what can we do? Again, work extra hard to recruit all we can in the next couple of weeks, and then shift gears and focus on doing the best we can at following up the patients that we have already enrolled. Use all of the reports and all of the tools available and be super proactive to minimize missed visits, to prevent loss to follow-up, to diligently record all of the data in the Combine forms and the Improved Care Now registry. And this is not only just the visit data, but the concomitant medications, the labs, the colonoscopy data, the adverse events, and serious adverse events. We are already far and away the largest randomized controlled trial in pediatric Crohn's disease history. What we can do over the next year is double down on follow-up and make this not only the largest, but the best and highest fidelity trial as well. It's 8:31. I'm sorry for going over 1 minute. I'm happy to stay on and answer any questions that you all have, but otherwise, thanks for joining. If you all want to talk or comment or ask questions, just unmute and do so. And like I said, Anne and I and Catalina will hang on for a few minutes. All right, well, hearing no comments or questions, I will also hang up. And please feel free to reach out by email or phone to any of us at any time. We are here to support you and your sites. Thanks for calling in.